Hello, everyone. My name is Divya Yogi Morren, and I am the Medical Director of the Pituitary Center at Cleveland Clinic and a clinical assistant professor at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. I have been asked today to go over the evaluation of pituitary tumors, specifically how it applies to diagnosis of acromegaly as well as Cushing's. So I'm going to start with the first slide about embryology, and this slide shows the development of the pituitary gland and how it originates from the Rathke's pouch or the oropharynx ectoderm, and that part goes on to form the anterior pituitary. And then if you follow the blue area, that's the neuroectoderm, that goes on to form the posterior part of the pituitary gland. Next slide. So the pituitary is formed embryologically from two separate parts, the anterior part and the posterior part. The anterior part goes on to produce 6 different hormones, and the posterior pituitary stores hormones. Next slide. Here we have the anatomy of the gland. This is looking at this on a coronal section. And you can see here that the pituitary gland sits very well protected in the sella turcica. And right above it is the optic chiasm. And if you look out laterally, you can see the cavernous sinus. And further out from there, we have the exit of the cranial nerves. So you can see right away from looking at this anatomy diagram that if the tumor in the pituitary gland were to expand superiorly, it will touch the optic chiasm and show up with visual abnormalities. If it were to extend inferiorly, it would go into the sphenoid sinus. And if it's a very large tumor that is extending laterally, it can cause involvement of the cranial nerves and cranial nerve palsies. And then next slide shows a sagittal section. We're still on the anatomy, but the sagittal section, and you can see from this where I circle the pituitary gland, that is right behind the sphenoid sinus, which is posterior to the nasopharynx. This next slide shows the blood supply of the gland, and you can see that up here you have the neurons that synthesize posterior pituitary hormones. They are up here in the hypothalamus, and if you follow these neurons down to the posterior pituitary, that's the neurohypophysis. That's where they store those hormones. And then the anterior pituitary gland is here in pink. You can see that the superior hypophyseal artery supplies the infundibulum as well as the anterior pituitary gland, and there's a portal circulation that supplies the posterior pituitary. Next slide. This diagram shows the pituitary gland and all the different organs that are affected. So if we start on the posterior pituitary, you can see that oxytocin has its effect on the breast and the uterus, and ADH has an effect on the prolactin. And then as we swing to the anterior pituitary gland, prolactin has its effect on the breast, growth hormone has its effect on the liver and then on bone. FSH and LH has its effect on the testicles in men and ovaries in women. ACTH has its effect on the adrenal gland, and TSH has its effect on the thyroid. This next slide shows the histology of the gland, and you can see here that this is a magnified image of the anterior pituitary stained with H and E that is showing 2 types of chromophils, pink, which are acidophils, and purple, which are basophils. And then over here, you can see the posterior pituitary gland to the side, where you mostly see nerve fibers and capillaries in that slide. This slide shows the anterior hormone cells and their secretory products. So you can see that the acidophils are somatotropes and mammotropes. They produce growth hormone and prolactin, and this is usually, these are organs that target the bones and they promote growth, and prolactin produces its effects on the breast to promote milk production during pregnancy. Then we have the basophils, corticotrophs. They make up about 20% of the gland, and they produce ACTH, which is trophic. Trophic means, it's from Greek, it means to nourish, and this promotes growth and secretory activity in other endocrine glands, specifically the adrenal glands. Corticotrophs also produce melanocyte-stimulating factor, and melanocyte-stimulating hormone targets melanocytes. Then we have thyrotropes, and thyrotropes produce TSH, and TSH targets the follicular epithelial cells of the thyroid. We also then have the gonadotropes, that's last but not the least. They produce FSH and LH, and FSH targets the follicular cells in the ovaries to promote growth of follicles, and it also targets the Sertoli cells of the testicles to promote spermatogenesis. Then LH targets the developing follicles and also promotes ovulation, and Leydig cells of the testicles promote secretion of androgens and spermatogenesis. So this is the slide that just shows the anterior cells and their secretory products. So we're going to move on to our first case, which is a 43-year-old female presents to her endocrinologist with newly diagnosed diabetes. The endocrinologist notes large nose and thick lips, a prominent supraorbital ridge, and unusually large hands. On questioning, she reports an increase in ring and shoe size. Her height has been stable at 5 feet 5 inches, but her weight is increasing. So based on this case, what are the possible explanations for her clinical picture? So a lot of these features that are mentioned in the case are, consistent with acromegaly. If acromegaly, it's caused by a growth hormone producing pituitary tumor. If it occurs after adulthood, meaning your growth has been completed and the epiphyseal plates have closed, then growth hormone has an effect that's visible on the acral areas of the body. So increased size of the hands and the feet. And you can see here in this slide where you can see three pictures of a woman at the top of the screen, and you can see how the acromegaly has progressed over many years. There's a delay in diagnosis of acromegaly, average about 6 to 10 years. So a lot of times the symptoms are so subtle that patients don't pick them up until they look back at their old pictures, and then it becomes quite obvious. And then if we look at the pictures down below, we see a woman with her hands up like this. You can see that her hands are thick, they're swollen, they're large. And then in the middle picture, we see a woman sticking out her tongue at us, and that shows macroglossia, where the tongue is almost too large to fit in her mouth. And when she sticks it out at us, we see indentations of her teeth on her tongue. And then this is a sideways view where you can see the prognathism, where the jaw has grown and become more prominent. Now, if growth hormone excess occurs prior to growth having ended or while the epiphyses are still open, you will get what we call gigantism. And you can see that in this picture where this person who is very, very tall, probably over 7, maybe 8 feet, standing next to someone of normal height, that this person had growth hormone excess while they were young. So they actually had increase in height or linear growth. And then you can see a picture of their shoe here next to a 12-inch ruler. And you can see that that looks almost 15, 16, maybe more inches in length. So then what is the most appropriate test to confirm diagnosis? So with acromegaly, this patient had tests done, and she was found to have a marked elevation of growth hormone and IGF. And then an MRI was done that showed a 9 mm pituitary adenoma. And next slide shows a diagram, actually an MRI of her pituitary MRI. And you can see here to the right of the gland, there is an area of hypointensity that represents the pituitary adenoma and possibly the source of her growth hormone excess production. So back to this question of what is the most appropriate test to confirm diagnosis of acromegaly? So this next slide shows the evolution of criteria for acromegaly diagnosis and evolution of therapeutic efficacy, which has changed over the years. So you can see here that there have been several consensus guidelines over the years that included IGF-1, growth hormone, and OGTT. That is quite clear in the first acromegaly consensus from 2000, the seventh acromegaly consensus from 2010, and even the Endocrine Society guidelines from 2014 still included growth hormone levels during OGTT for diagnosis, and for therapeutic efficacy, they still utilized random growth hormone levels being less than 1. So this criteria has evolved over time, and you'll see that it has shifted towards IGF-1 levels over growth hormone levels and growth hormone nadired after OGTT. And this has happened because of there are limitations in growth hormone testing. The reliability of growth hormone can be questionable. Plus, it is affected and influenced by things such as age, gender, and BMI. Additionally, the OGTT has limited ability in patients with mild growth hormone secretion and on those on medical treatment, where growth hormone suppression has been shown not to correlate well with disease activity. So IGF-1 levels have emerged really as the front runner in terms of testing for diagnosis as well as therapeutic efficacy target. And those levels are more stable, consistent, and reliable for diagnosis and monitoring. So at the bottom of this table, when we get to the 14th acromegaly consensus from 2024, the criteria for diagnosis is merely IGF-1 levels of more than 1.3 times the upper limit of normal for age and for therapeutic efficacy targets, it's IGF-1 normalized for age. There is utility for OGTT in certain situations where you might have a borderline IGF-1 level, and that remains here to be used at the clinician's discretion. So there are more sensitive assays for both IGF-1 and growth hormone, which has increased the diagnostic accuracy. There's better age-specific and gender-specific references, and this is very crucial for us to have reliable IGF-1 measurements in acromegaly patients. And the oral glucose tolerant test, when it's used, there's an updated nadir growth hormone cutoff, which we will talk about, and there's standardization results across these different assays. So we'll go a little bit more into the IGF-1 assays, which is going to be the mainstay of what endocrinologists use for diagnosing acromegaly. So the IGF-1 assay, there's increased sensitivity and specificity, specifically because we use ultra high performance LCMS. This has led to an enhancement of diagnosis because it offers a more precise, reliable measurement with reduced variability and cross-reactivity compared to the older references. Then we have the standardized reference ranges, which are easier to use in different populations. There's also enhanced diagnosis, which we've already spoken about. And then I want to touch briefly on polymorphism insights. If you measure IGF-1 and IGF-BP3 gene polymorphisms, such as the IGF-1 CA19 variant, they correlate with IGF-1 levels and disease severity that helps predict treatment outcomes and tailor therapies. Here we have a table on the next slide that is comparing IGF-1 immunoassays and mass spectrometry assays. And mass spectrometry has really refined IGF-1 testing, and it offers superior sensitivity, specificity, and accuracy, which makes it a really valuable tool for diagnosis and management. I want to highlight a few things on this table, which I have highlighted. So I want to highlight the high specificity by distinguishing IGF-1 from other proteins, which minimizes cross-reactivity for increased sensitivity. I also want to highlight the broader dynamic range, which captures low and high IGF-1 levels more accurately, which is crucial for detecting subtle changes in acromegaly treatment. And then lastly, I will highlight that the mass spectrometry assays resolve IGF-1 from IGF-BPs via chromatography, which eliminates the need for complex pretreatments and reduces interference. So overall, things have definitely gotten better. A word about some specific polymorphism studies. The IGF-1 CA19 is linked to higher circulating levels of IGF-1 on more invasive tumors, and it's less responsive to treatment. So that's helpful information to have when you're trying to tailor your treatment strategy or algorithm. IGF-BP3 in 202AC polymorphism, it influences IGF-1 binding protein. It can modulate IGF-1 bioavailability. It can lower IGF-BP3 levels, and it's correlated with a need for additional post-op treatment and indicates more aggressive phenotype. So these variations in the IGF-1 gene can be associated with treatment efficacy, and they may serve as predictive markers that can help aid in the personalization of acromegaly treatment strategies. Next slide. So I did mention that we were going to come back to the OGTT. And although there are limitations to the OGTT, as I've mentioned, refinement of OGTT growth hormone suppression cutoffs, such as lowering growth hormone nadir to 0.3 microgram per liter, does provide a more accurate reflection of disease remission, specifically in cases where the IGF is equivocal. The other thing is when you're looking at this, you want to make sure you look at both the baseline growth hormone levels as well as the nadir growth hormone levels, and you can use that in collaboration with your very sensitive IGF-1 assay. This is just enhances the diagnostic specificity and decreases any false positives. So I wanted to show this slide of, you may be familiar with this celebrity, Andre the Giant. He was a very famous wrestler back in the 1980s, and he was purported to have a pituitary tumor causing acromegaly. And you can see here, very impressive, his birth weight was 13 pounds. He was 6'6" at age 15, and they think his adult height was over 7 feet. His adult weight was over 380 to 500 pounds. His shoe size was 22, and it's reported that he could drink 100 beers or 20 bottles of wine in one sitting. And I also wonder if he may have had some of the consequences of acromegaly, the skeletal symptoms, such as back pain. He had ankle fractures, back surgery, and eventually he died from what is presumed to be congestive heart failure. I put this slide up here to really demonstrate that this was a case that was visible to many people because of his profession, right? But a lot of our acromegaly patients are not going to experience such drastic symptoms, and they will experience diagnostic delay. Delayed diagnosis leads to more time to develop complications. And the complications of acromegaly, as you all know, are not benign. We are talking about increased risk of hyperglycemia, hypertension, hyperlipidemia, pulmonary disease, obstructive sleep apnea, possibly increased risk of certain cancers, and cardiovascular disease. So it's very, very important that we use the things that I talked about in the prior slides to make sure that we are being proactive in diagnosing patients with acromegaly by using the IGF-1 assays and the other testing as needed. So we're going to our second case. Next slide. So 45-year-old female presents with a 2-year history of progressive weight gain, primarily around her abdomen and upper back. She reports that despite following a diet and exercise regimen, she continues to gain weight. Additionally, she has noticed an increase in facial rounding, moon face, and unusual fat deposition between her shoulders. That's the dorsocervical fat deposition, colloquially called a buffalo hump. She feels persistently fatigued with low energy levels that impact her daily activities. She also reports muscle weakness, particularly in her arms and legs, making it difficult for her to climb stairs or carry groceries. Next slide shows Cushing disease, and this is what I believe this patient has. I think from the stem of that question, the clinical features, it's quite easily to surmise that she possibly has Cushing disease. So Cushing's disease is an excess of cortisol levels that are ACTH dependent and come from a tumor of the pituitary gland. This is separate from Cushing syndrome, from an adrenal etiology, which we are not discussing today as we are focusing on pituitary conditions. Cushing disease is diagnosed through a combination of your clinical assessment, your lab studies, as well as your imaging studies. The goal here is to confirm excess cortisol production and determine whether the cause is due to a pituitary adenoma, which characterizes Cushing disease specifically. Next slide. So the next slide shows the 24-hour urine-free cortisol. And urine-free cortisol is one of the tests that we use to test for hypercortisolism. It has a good diagnostic sensitivity and specificity. It has high diagnostic performance for Cushing disease. Urine-free cortisol levels above 170 nanomoles in 24 hours provide 98.7% specificity and 100% sensitivity for detecting Cushing syndrome in new cases. The techniques for measurement, there have been methodological advances as well. Measurement accuracy has improved with liquid chromatography tandem mass spec, which minimizes cross-reactivity issues that are common in immunoassays. The limitations and considerations of this test are that urine-free cortisol results could be unreliable in patients with compromised renal function. However, the clinical utility is good and it is a sensitive and a non-invasive test. So we'll move on to the next test, which is late-night salivary cortisol testing. There have been different tests done proving the utility of this test. Specifically, I'm going to talk about a meta-analysis by Carroll et al. From 2009, where the late-night salivary cortisol demonstrated a sensitivity of 92% and a specificity of 96%. This is a reliable, non-invasive screening test, and late-night salivary cortisol is an accessible first-line test. The benefit of this is that the patient does it at home, they do it at their bedtime, so it's beneficial for outpatient screening due to its ease of collection and ability to perform the test in a non-stressful home environment. And in clinic, you can very comfortably just give the patient the salivettes and tell them, take these home and check the late-night salivary cortisol. There's one thing I have learned to do. I used to give out 2 of these at a time, but now I give every patient 3 saliva tubes. Because if you give them 3, you already have a tiebreaker in there. There's a chance that at least 2 of them are going to say the same thing, and you're not stuck with one being abnormal and one being normal, and you don't know what to do. If you send them home with 3, you already have a tiebreaker. So that has been helpful. The other thing is to make sure you tell them to do this on 3 consecutive nights. I have had a patient come and tell me that he did all of the tubes one at a time on the same night within 5 minutes. That's what he interpreted as consecutive. Very important to make sure the patients understand consecutive different nights. So we'll go now to the low-dose dexamethasone suppression test, which is the test where you give a low dose of dexamethasone, usually 1 milligram of dexamethasone to be given at the patient's bedtime. And then the next morning, they have to get their cortisol levels checked. There have been studies by Findling and Raff, referenced at the bottom of the slide, that shows a diagnostic threshold of serum cortisol suppressing less than 5 has a high sensitivity, making this an effective screening tool for confirming Cushing syndrome. And then there is some good diagnostic discrimination. If you combine the low-dose dex suppression test with CRH testing, that yields a sensitivity of 97% and a specificity of 94% for differentiating between ACTH-dependent forms of Cushing syndrome. So this third test has utility as well. I want to go through this table. This slide shows the sensitivity and specificity of low-dose dexamethasone suppression tests. I've referenced 3 articles, and I have compared their sensitivity and specificity with comments in the last column. In the study by Asidori et al., there was a 98% sensitivity for low-dose test alone, 97% sensitivity of low-dose combined with CRH. But if you look at the specificity is quite important. The specificity for the low-dose text was 79%, but when combined with the CRH, the specificity went to 94%. So this is something that's helpful, and it tells us that the low-dose dex test, when combined with CRH, improves the specificity significantly. The other row shows a study by Martin et al., where there was a 100% sensitivity and an 88% specificity of this test when you use 50 nanomoles per liter as a cutoff. And the last study by Jing Tao in 2012 shows a 97% specificity, 99.6 using a cutoff of 50 nanomole. And if you look at the specificity, also quite good at 98.9% if you use the cutoff of 146.5 nanomoles per liter, and 89% if you use a cutoff of 50 nanomoles per liter. So when you lower the cutoff, you increase the sensitivity, but you may decrease the specificity. So To confirm hypercortisolism, if you get any one of those screening tests that we just discussed positive, you want to confirm with one or more additional tests. And the criteria for hypercortisolism is that you must have consistent elevation in the urine-free cortisol or elevated late night or lack of suppression in low-dose DEX suppression tests. You must have at least 2 out of 3 tests being concurrent to either rule in or rule out the diagnosis. This slide shows how we determine the source of hypercortisolism. Because once you determine that somebody has hypercortisolism, the next step is to determine the source. And you do that by first measuring plasma ACTH. If you have a low or undetectable ACTH, this indicates an ACTH-independent cause, likely adrenal. So you move away from the pituitary gland and focus the rest of your testing and imaging on the adrenal gland. The next step in that case would be to perform adrenal CT or MRI to identify an adrenal tumor. However, if you have a normal or elevated ACTH, this indicates an ACTH-dependent cause, pituitary or ectopic, and then you move to the next step, which is to differentiate between a pituitary source as well as an ectopic source of Cushing's. This slide shows the localization of ACTH source in ACTH-dependent cases. IPSS is the gold standard to differentiate ectopic Cushing's from pituitary Cushing's. If you do your pituitary MRI and a pituitary adenoma is detected, Cushing's disease is likely. If you do an IPSS, if your MRI is inconclusive, you don't see an MRI, and you do not see an adenoma on the MRI, you need to move to IPSS. And the basis of this test really is you compare the ACTH levels in the inferior petrosal sinus versus what's coming out of the peripheral blood after CR8 stimulation. And you're looking for a high gradient IPSS gradient of more than 2.1 compared to periphery. And after CRH, these gradients usually get even higher than 3 to 1. And that would confirm a pituitary source of Cushing's disease. If you have low or no gradient, then it's possible that the source is ectopic. So this final slide shows a summary of the decision path, where your first step in Cushing's is to confirm hypercortisolism with urine-free cortisol, late-night saliva cortisol, or low-dose DEX suppression test. Then you want to measure the ACTH to determine whether it's an adrenal or pituitary source. If there's low ACTH, this is called ACTH independent, and then you need to move to the step for adrenal imaging. If it's high ACTH, then that's ACTH dependent, and you need to differentiate between a pituitary or ectopic etiology, which is the last part where you perform IPSS to differentiate between pituitary and ectopic ACTH sources. So that was a tour of how to diagnose acromegaly as well as how to diagnose Cushing's disease, specifically directed towards pituitary tumors. And that will end my talk today. And please feel free to contact me if you have any questions.